Good morning. So you have to do the little disclaimers right out of the gate. I am at the Oregon Research Institute. That's one of my jobs. One of my other jobs is with Functional Family Therapy, LLC. I co-own that dissemination organization where the mission is to move evidence-based functional family therapy from research to practice. And so I do receive compensation with my other job. So everything that I have to say today, keep in mind that there is a conflict of interest there. Always fun to start a presentation, very engaging with the conflict of interest statement. So talking to a group like this is tricky. Trying to make the decision about what's the right tone or what are the right themes to hit is a struggle. So I'm going to try to talk about things at hopefully a broad enough level that those that are interested more in the practice elements of it will get a flavor of what are some of the challenges and what are some of the future directions and where we're going in the field of family therapy for adolescents with behavior problems. But also give you a flavor of really what research has shown works, why it might work, and then what are the challenges of bridging that gap between research and practice. And it's intentionally going to be pretty much at a theoretical level rather than just simply coming up here and saying, study 1 found this, study 2 found this, study 3 found that. Part of that is I just get bored hearing myself talk about what the studies say all the time. And I'm assuming in an audience like this, especially in the third day of a conference, you don't just need to see more numbers just laid out in front of you. So I thought I'd start with something a little bit different. How many of you guys do family therapy? Okay, more than half of the crew do family therapy, or at least some form of family therapy. Those of you who do family therapy, keep your hands up. How many of you guys do parent-child, some kind of parenting intervention? Okay. How many here only do individual or group therapy? Okay. Don't be proud. Come on, be proud. All right. So I'm preaching to the choir here for the most part. And so hopefully for those of you who have a different background from individual or group, some of this stuff will resonate still because I think the challenges around moving things from research to practice are relevant for everybody. For those of you who do family therapy, I'm going to say a few things, and we're going to spend some more time in the afternoon kind of talking about these together for those of you who are in my workshop to talk about exactly what it is family therapists might do when you encounter certain things. But a few of the more compelling comments that I've heard recently in sessions in delivering functional family therapy, things like, she lacks, I don't know, what do you call it? She just lacks that human thing, She's evil. Everything would be good if it wasn't for her. You know what? We adopted the wrong fucking kids. These ones are rejects. You're such a hypocrite. You tell me not to do it, but you do it all the time. Maybe I would come home if you weren't always drunk. Take your headphones off and listen to her. That's why we're here. To the therapist, some of you might be more relevant than others. Do you have kids? You know what? If you don't like it, there's the door. This is my house. I'm done. I'm done with him. I'm sick of being a parent. He needs something else. He needs somebody to come in here and knock some sense in him. He needs somebody to pound something into his head. To Dad, you didn't raise me. I have no respect for you, punk. Sound familiar for some of you guys who work with behavior problem kids? Yeah. Terrifying for those that are just starting their career. Yeah. So the interventions I'm going to be talking about today really were cutting their teeth on working with the types of families that come in and say those statements that I was just going through here. In the late 70s, early 80s, there was a quote that I love that I've seen presented before by Saul Garfield that says, "Yes, I have heard of family therapy, but opinion is no substitute for data." Over the next 15 to 20 years, there are few places in the evidence-based arena that got as much interest and traction in demonstrating outcomes as family therapy models. Ironically, even though family therapy has done an amazing job consistently demonstrating positive effects, when you look into the training programs in psychology, in marriage and family therapy, and in social work, it is rare to see an evidence-based model presented. When you look into practice settings, of the kids who could benefit from an evidence-based intervention, about 8% of the kids that could benefit from an evidence-based treatment actually receive an evidence-based treatment. 92% of those 50% of the kids who get services, the majority don't get services, 92% of them are receiving interventions for which there is no evidence. Not that they don't work, but at this point there's no evidence. So I'm going to talk a little bit about what's gone on in terms of the evolution of family therapy. You already hear my reason for my disclaimer. I'll say things like functional family therapy. It sneaks in there. By the mid-90s, it's been pretty clear that there were a lot of things that worked for kids. And when you looked at the blueprints for violence prevention, overwhelmingly the models that were represented for kids that were violent had a family-based component to them, no surprise. Some of the family-based component included parenting. Some included nurse home partnerships, actually going in prior to birth and doing parenting work and supporting typically marginalized, poor, inner-city moms-to-be. And you could actually see 15, 16 years later the prevention of violence for that intervention. So there's great stuff that we know works. There's also stuff that we know doesn't. What we know does not work are boot camps, wilderness programs, Scared Straight. Not only does Scared Straight not work, Scared Straight has been consistently associated with iatrogenic effects. Doesn't stop A&E from continuing to push Scared Straight out there, because it's one of their biggest selling programs. People like that. They love that notion of kids, what they need is to have somebody get right in their face and tell them what to do in a very disrespectful way. It not only doesn't work, it's actually harmful for kids. So we got a lot of evidence now. So there's been a real evolution from, great opinion about family therapy, but opinion is no substitute for data. Well, we got the data. So I think it's really important for us to spend some time as we go through the presentation talking about what does that data mean, especially now in a context where people are very, very sensitive to facts and opinions, because this has policy implications. This is how money gets spent. People will say things like, you know what, scientists, they can kind of make things up to conform to whatever they wanted the data to say. And as long as you can make that statement, you do not need to be held accountable for your work, because the facts don't matter. So it's really important for us to spend some time talking about, well, what does this facts kind of mean? What does the data mean? By the way, that's not meant to be politically one side or the other. That's just the reality of how decisions get made. I feel like I'm getting on my soapbox already. God, that's why I hate talking in front of this many people. I'm looking forward to the afternoon where it's much more personal and engaging. We talk about the clinical side. I'm actually a therapist by training first, and then the scientist second. So it's important to have a conversation about who are we talking about. We're not just talking about kids that come in that are delinquent, or a kid who comes in he's substance using, or a kid who comes in and he's oppositional, a kid who comes in because he doesn't go to school. We're talking about a constellation of things that tend to hold together. Not all of these things are present in every single case you work with, but you're treating youth and families. You're not treating a disorder. And so when somebody comes in to your clinic or you're going into their home, which overwhelmingly the work in the real world is moving towards, is much more home-based work. When you're moving and doing your work in somebody's home, you're working with the individuals in the family, with all they bring in. So you could have depression, you could have anxiety, you could have substance use, you could have truancy, you could have trauma, you could have parents who are using, you could have parents who have no ability to parent. You could have parents who only have limited ability and they continue to do that over and over and over again, even though it doesn't work, because that might have been what worked when the kid was little. There's a whole host of things we're working on. So I just wanted to make sure you guys have a general sense of the kids we're talking about are not some narrowly defined treatment population that's only brought in because they had substance use or delinquency. You can have a very oppositional kid who does not go to school because they're hanging out with their friends and they're more interested in using. That's very different than a kid who is not going to school and is oppositional, but is terrified that if they go to school, their mom may kill herself. So you're working with families and everything they bring in, not just a disorder or a target behavior. Unfortunately, the field is becoming so narrowly defined around a target behavior. Now what happens is like, okay, so you work for substance use, but what about autism? You work, or Asperger's. That was 2 or 3 years ago. Every single program had to justify their existence in the real world, even though they're working with violent kids, for kids that were some level in that developmental spectrum. Now, it's okay, great, you guys are working very effectively for delinquency and substance use, but what about trauma? Trauma is the new buzz. And if you're not trauma-informed or trauma-based, then you're not doing your work. Very important to keep in mind that all of these evidence-based programs, if they are not trauma-informed, they would not be effective. It does not mean they're evidence-based for trauma. But the kids that are coming in, historically, they've seen violence on the street. They've perpetrated violence. They've been victims of violence. They've seen it in their homes. Increasingly, we are seeing the kids being the perpetrators of violence in their homes. One of our first youth that we brought into one of our implementation projects in New York City, the referral was he went to school. Mom saw him off, made breakfast for him. 17-year-old kid goes to school. She takes her younger kid to school, comes back up the walkway. He had circled back around the house, and he stabbed her in the face. That was one of our first cases we saw in the study. That case was treated in an outpatient intensive family therapy program. This kid was not hospitalized. This kid was not taken out of the home. We were able to keep them in the home and demonstrate massive positive effects for them. But the violence is going both ways now, and it's cutting across generations. Grandparents to kids, kids to grandparents, aunts, uncles. There's a lot of people that are involved in it. So that's the sense of the families we're working with. So when we're talking about evidence-based program, that's kind of the who. I think it's really important to talk about the who part first, because it's very easy for all of us to make the statement, yeah, but what about our kids? This might have worked over here, but what about our kids? Most of this research has been demonstrated with marginalized, underprivileged, poor inner city families. Most of the research has been demonstrated across racial and cultural groups, across age, and across gender. So the effects of these models are very robust. A little bit more with respect to adolescent drug use, and just something I wanted to mention here. This data holds year to year. When you look at the causes of youth mortality, other than HIV, AIDS, you just look at what's going on in terms of the social, behavioral, and environmental factors that are the primary causes of mortality worldwide. Unintentional injuries and substance use is significantly involved in almost all of those unintentional injuries. Homicide, suicide, substance use is consistently implicated there. Cancer and heart disease, it's not. Those are preventable. Those are behavioral and social issues that we can actually change. So we are not just talking about improving behaviors here. We're talking about increasing mortality. So I don't want to just get too dramatic, but I think this is dramatic. I think when you get kids out of harm's way, and you get them out of harm's way faster, we're doing a good job for our communities and the families. The great thing is we're also saving money, because typically the work we're doing to actually decrease these problems is more efficient, we do it faster, and it has better long-term outcomes. Okay. Are we okay so far? Am I still too far up on the soapbox, or? Okay, all right. So what is family therapy? given that we have so many of you guys in here that already are family therapists. I'm going to keep it very broad here. We're talking about interventions that are based in a systems understanding. Interventions that understand the influence of context on individual, where interconnections are a primary target of treatment. Not necessarily to the exclusion of individuals, but interconnections take precedence. That has implications for determining who we work with. And so most of the interventions we're talking about here tend to work either with a dyad, parent-child, or with a larger system. Some interventions are pretty rule-based in how they make the decisions. Everybody who lives in the home should come to treatment and needs to be there for every session. Other interventions have a little more flexibility. Who is necessary to begin a process of change? Who can shut that process of change down? Who does the referral source thinks need to be there? And who does the family thinks need to be there? It's a kind of decision for who we're working with. So it's larger than just an individual. So most of these interventions have multiple people that are included inside of sessions. Multiple people, when you're talking about family, does not mean biological mom, biological dad, and kids. We look more around functional roles, and it's pretty common for us, by far the most common thing we see in our implementation of functional family therapy is about 60% of the cases are single mom with kids. We are seeing an increase now. It's even approaching around 5 to 10% of single fathers with kids. And then the rest of it is some mix. The smaller level of mix is actually two-parent biological parents. It tends to be much more of extended family, grandparents, aunts, uncles, older siblings that are serving in parent roles. So that's kind of the who of what we're talking about here. A hallmark of a lot of the work that we're talking also is that the interconnection work is not done to create simultaneous individual changes. The idea is there's something about working in that space in between people where you can bring about change. And so most of the interventions start in that space between. Doesn't mean they stop there, but that's where these family models all share that common kind of focus. They cut across a range of older school family models. You don't see a lot of the post-constructive, the social constructive and postmodern interventions on these lists. Not that they're not effective, they just haven't been studied in that way. It's much more of a kind of case-by-case evaluation from that perspective. And so they haven't risen to the status of being quote-unquote evidence-based yet. So a lot of the family models we're talking about here have a foundation in structural family therapy, Salvador Minuchin, or strategic family therapy, Jay Haley. Others are a mix of attachment theory and cognitive behavioral therapy and systems theory. That's kind of the general frame of what we're talking about in terms of these family therapy models. All of these interventions are organized to systematically address risk and protective factors across multiple domains. So the idea is you're thinking not just about a larger system, you're thinking about everything from the cellular level to the social context. If you're not able to attend to the individual variables and keep them in mind, you're not doing a professionally responsible job. You need to know what are the risk variables at every single one of these levels. In interventions like functional family therapy, early on in treatment, you're going to be addressing the family level variables first, and then you'll be rolling in some of those other individual and peer factors later. In multisystemic therapy, you're going to really zero in more on the parenting variables right out of the gate and add all of the social context, peer, school, medical, along the way. We okay so far? Okay. It really doesn't even matter which interventions you're looking at. All of them have a notion for organizing risk and protection across these domains, using more of a Bronfenbrenner type of framework, understanding that kids exist inside of certain microsystems. The family, the school, the peer, and the justice system are really the four that are the most relevant for most of the work we do. and our job is to try to influence as many of those systems as possible. Most of the family interventions operate on the assumption that when families are doing their job, they are actually serving roles, functional roles, and adaptive roles in all of these contexts. Parents appreciate the importance of involvement in school. Parents support school involvement. Parents are aware of where their kids are at and who they're with. Parents are connected to the peers of their kids, to the parents of their kids' peers. So the parents are connected and have dexterity to move across multiple systems. Kids are adaptive and functional in multiple systems. The interventions that I'll talk about later, it makes you dizzy. I was trying to hypnotize you, so you love therapy. Yeah. All of the interventions you're talking about fit into this framework here of individual to ecological and prevention to treatment. So everything I talk about later, I'm going to be grounding it here. So I'll talk about some ideas around how this might play itself out just really quickly. So in functional family therapy and multisystemic therapy, these are two of the most widely disseminated interventions right now. I think MST is now approaching 500 sites worldwide. Functional family therapy, we're at about 380 sites worldwide. Annually, we serve about 50,000 families. We have around 3,500 therapists that are involved with the work we're doing. The interventions are quite different. So in multisystemic therapy, I'll just pick one risk factor here. Let's pick a risk factor that we know that's kind of the intersection of parents and peers. We know that parent monitoring and supervision, effective parent monitoring and supervision of youth activities is a significant protective factor for kid delinquency and drug use. So one of the things that often gets targeted for families where this is a problem is monitoring and supervision. In multisystemic therapy, which is very parent-driven, therapists will position themselves to support 24/7 that parent to make sure they have the skill to consistently and appropriately monitor and supervise their child's activity. No matter how much that kid fights it, no matter how much that kid pushes it, no matter where those limits and how many times they fail, they're going to continue to help that parent build them up and build them up and build them up until the kid starts responding. And they expect a lot of failure up front as they push that through. So parent follow-through is a real key element of multisystemic therapy. In functional family therapy, there's a different frame for how we approach monitoring and supervision. If you have a family where the relational functions, that's the functional part of FFT, doesn't refer to their adaptive or functional, it refers to what are the functional payoffs in the individual relationships that people get through their behaviors. If the relational function is the parent has more influence over the child, we will look very much like MST. We'll go straight to working with the parent and skill them up to monitor and supervise their activities. But if the relational function is more egalitarian, or the kid is actually one up, we are not going to die on that hill of trying to build the parents' skills. We're going to accommodate to them and their relational functions, but give them new behaviors that are more adaptive. We'll still address it, but instead of approaching things as we're going to skill the parents up, we're going to start with what's the most significant predictor of kids' willingness to disclose where they're at and who they're with. Because the best predictor of monitoring and supervision is not parent skills. It's actually kids' willingness to tell their parents where they're at. Kids' willingness is not predicted by parent skills in discipline and asking about it. It's actually predicted better by parents respecting their kids. So we'll move to a relationship and respect-based approach to match to the relational function of the family. So the interventions in all of these evidence-based models work. How they get there looks a little bit different, and how you organize to address these multiple risk and protective factors becomes really important. So I hope that helps to kind of like make some of this slide real about how things cut across multiple domains. So the models that I'll refer to throughout are brief strategic family therapy, functional family therapy. So BSFT, by the way, is actually grown right here in Miami by Jose Shopaznik at the University of Miami. Functional family therapy, Jim Alexander at the University of Utah. Multidimensional family therapy, Howard Little is also here. He was at Temple University before, now he's down here at Miami. Treatment foster care Oregon, Patty Chamberlain's work. And multisystemic therapy, the work by Scott Hengler and colleagues at the Medical University of South Carolina. On the parent training side of things, the interventions that are also recognized as being effective are, this is a short list. PCIT is part of the United Kingdom part there too. Triple P, PMTO, Parent Management Training Oregon, Nurse Home Partnership. So when you look at the list I'm going to show later, you'll have a larger understanding of what at least one of the lists says are evidence-based programs. All of these interventions don't just try to tackle everything simultaneously. There's a real understanding of what are the immediate, intermediate, and long-term goals of treatment. So at any point in time, you have a sense of where you're at with the family. There's a clear articulation of a model. By far the biggest challenge to the implementation of evidence-based practice are therapists being unwilling to only operate from one perspective, wanting to be more eclectic and integrated in their work, which is understandable. But without a well-defined theory, you're floundering. Very important to have a really clear sense of what it is you're trying to accomplish, what it should look like in every single session. So you need to have a real good sense and grounding in what are the techniques and strategies of your model and the overarching goals. One of the characteristics also of these interventions is they're not paint-by-the-numbers approaches. These interventions are very much flexible and responsive to what people bring in. And so there's a tremendous amount of flexibility and creativity in them also. In terms of the what part of the evidence-based we're talking about here, if you're asked, and this is kind of one of the goals here, kind of like, well, what makes something evidence-based? From my perspective, the evolution of any model should be through the interplay between theory, research, and practice. So when you have theory being informed by what it is you're seeing in the room, and you have research that's continuing to demonstrate the impact of different interventions that might work, those that seem to have no impact, and those that actually seem to be influencing the process, now you're starting to talk about what I would refer to as evidence-based. I don't think that even if you are zeroing in on what it is therapists are doing, but you have no demonstrated outcomes, that we should be continuing to do interventions that look great but don't produce results, that feel good but don't get long-term outcomes. So what we're talking about here are interventions that actually have a real solid foundation in what we refer to as efficacy studies. An efficacy study is a randomized controlled trial where the investigator is working hard to try to rule out as many competing hypotheses as possible to determine whether or not intervention A is more effective than intervention B. In all of the randomized trials for the interventions that I referred to on the slide before, there was an independent evaluation that included the assessment of youth and family functioning at baseline and at multiple points over time, including, at a minimum, 1 year post-treatment outcomes. A randomized controlled trial also includes some control group. Sometimes those control groups are actually active treatments. Sometimes they're waiting list. Sometimes it's treatment as usual. That's the hallmark of most of the evidence-based work we're talking about here. Interventions like multisystemic therapy have also been replicated across multiple teams. And there's numerous studies on MST. Sheila Iberg and PCIT, multiple studies demonstrated the impact across multiple teams. So you have independent replication. So we're also talking about impact in single studies, but replications in many. Effectiveness work is taking that now from the controlled kind of research setting said, well, yeah, it works there, but when you take this out and move it into practice, into the real world, do you get the same effects? Typically, effectiveness studies include real-world therapists from community agencies, and clients that are being brought in to a community agency as opposed to kind of a research-based setting. The focus is much more on the external validity, so how much it actually works in the real world, as opposed to trying to control for all the competing hypotheses to make sure you deliver the pills, the most effectively. So what you get is a shift in focus from kind of the internal to the external. So yeah, it works here, but does it work over here? All of the interventions on the prior page have been shown to have an impact in the real world. The blueprint models that I'll be talking about in a few minutes also have a variety of implementation and dissemination studies. And I'll mention one of those in FFT. So not only is it working in small-scale studies, like effectiveness studies, but it's also working broadly across the community. I'm going to kind of move forward a little bit more here, just to give you an idea of some of the outcomes that these interventions have demonstrated. When you look at adolescent outcomes for substance abuse treatment, the engagement and retention rates for treatment as usual are abysmal. Around 25 to 40% of the kids that get referred to treatment actually end up getting treatment. Overwhelmingly, kids either do not show up for a first session or do not come back for a second session. The evidence-based family models have success rates around 80 to 90% of kids get engaged and complete treatment. So that's a nice outcome. At least you get them hooked in. In the trial that I was involved with brief strategic family therapy, treatment as usual, we ended up this is treatment as usual across 8 teams throughout the United States. The African-American kids in treatment as usual, 1 in 4 were able to successfully complete treatment. Unacceptable. In BSFT, the rate was above 60%, which is still not ideal. Almost 1 out of every 2 kids we were still not getting through a full course of treatment. Family functioning, great improvements in family functioning across all groups we're working with and across all of these models. Improvements in family functioning is not the prize, though. A lot of families say things are a lot better, and the kids continue to struggle. If you do not put things on the table like conduct disorder and substance use, it is not going to change over the course of treatment, no matter how much the family learns to communicate with one another using I statements, no matter how much they learn to resolve their differences of opinion about topic A. You've got to get these things on the table. So it's very important when you look at the evidence-based work for kids with behavior problems, when you're getting outcomes, you're seeing conduct disorder and delinquency being an active part of what's talked about. Drug use is critically involved in almost all of the sessions where the kid is a drug user. It is not uncommon for family therapists that are working with drug users to bring in things like coping with urges and cravings, identifying triggers, teaching youth and family members how to urge surf, using CBT or mindfulness as a foundation. So what is the thing we know? I'll go into therapist voice. And one of the things we know about urges is they grow, and they grow, and they grow, and it gets to a place where you can't control it anymore. It's almost like a wave. Just imagine yourself standing outside on the beach, and you're seeing that wave grow and grow and grow. What's the one thing we know it's going to happen, though? It's going to dissipate. So as that urge grows and grows and grows, and it gets to that place where it's highest, this is where we want to do our work, to help you have skills to get through that moment in time where it's at its greatest. Not uncommon to have that be a real key part of what we're doing in our work with the substance user. If you don't put that kind of content on the table, you're not going to get change in substance use in the evidence-based family work. Good news, HIV risk is the only variable that we have seen in our own research that changes spontaneously, even if it wasn't a specific target of treatment. Kids that received evidence-based group therapy and evidence-based FFT actually changed their HIV risk, even though it wasn't an active part of what was discussed in the sessions. fewer sexual partners, and fewer unprotected sexual episodes. Not a bad secondary outcome. Kids tend to go to school more and do better academically as a result of these family interventions. We've seen the impact on internalizing disorders for youth and parents. Parents have less distress after receiving an intervention like MST or FFT. And parent drug use is also decreasing over the course of implementation of these models. The big ticket items that mean a lot to community agencies are that we see a reduction in incarceration, residential placement, and foster placement. Kids stay in their home. So there are a lot of places you guys can go to kind of see what it is that people have said are these evidence-based models. A couple of the really kind of the ultimate ones are the Blueprints for Violence Prevention, and also John Barron's National Clearinghouse. Those are really, really good places you can go and look at what are the lists and what are the criteria that they're using to say whether or not something actually is evidence-based or not. If you're interested in in trying to figure out like what are the costs to your community, what's the likelihood you're going to get a better bang for your buck, the Washington State Institute for Public Policy has a fantastic website. I'll show you a slide in a second that gives you a sense of how they organize their information. The Washington State Institute for Public Policy has had some of the broadest social impact of any state in the country on bringing in evidence-based practices and having it shape where money gets spent. They were able to take the data from the state of Washington and shut down the plans to build another prison and funnel the money into evidence-based outpatient services based on their outcomes, which is a great thing. Battling the prison lobby, guys, I mean, that's a huge one. That's a big business. It's much more big business than just putting people away. There's a lot of money at stake there, and kids do a lot better when they stay in the community. We know that, but we still like to put them away. This slide is unreadable, I know that. But it gives you a sense. When you get on the Blueprints website, if you just go to what are the criteria, they have two designations. They have a promising program designation, and they'll have a blueprint program designation. And the types of things they're looking for here is there really specificity in the intervention? Kind of know what the people are doing? Have they described it well? What's the quality of the evaluation that's been done? What's the impact of that intervention? And how ready is it to be taken to scale? So they really want to make sure that it's not just that it works, but that you can actually take it in the community and replicate it. If you can't take it in the community and replicate it, then why bother? The next criteria there is around what are the model programs. And here is you're talking about multiple studies. That's one of the big difference with a positive impact. And they even have now what's referred to as a Model Plus designation, which is talking about independent replications as well. So there's a lot of integrity that goes into making a decision about whether or not something is quote unquote evidence-based. And here are the current kind of lists on the Blueprints program when you get on their website. And I put the website on the bottom there. But if you just type in Blueprints for Violence Prevention, you're gonna see it. These are the interventions that are currently listed on that program. Just kind of a historical context for this. The Blueprints for Violence Prevention really came into existence on the heels of Columbine and on the heels of the zero tolerance policies in schools. And so basically what ended up happening was you had a massive event that traumatized the entire country. People were very worried about things. They kick into effect a zero tolerance program that actually does not work and was poorly implemented anyway. And they needed to figure out something else to do. So the question is, what is available out there? And they reviewed at this point probably around 10,000 different research studies to identify a small list. And there were a group of 11 programs that were originally identified. Since that time in 1998, it's grown a little bit, and they've now expanded it beyond violence to a variety of other outcomes. This is only one of the lists. It happens to be one that maintains one of the highest levels of integrity. I'd mentioned before that the National Clearinghouse by Barron, it even has a more stringent criteria than Blueprints. The National Registry of Effective Prevention Programs, it's basically, do you have an evaluation and do you have a pulse? And you're going to get listed as being effective. And so I don't find it really all that helpful. So that's great, but what impact does it make other than a bunch of scientists kind of hanging out and talking about this crap? And it really doesn't change anything. There's been an enormous amount of effort in bringing these things to scale. And I think the blueprints, that's why I highlight them, they were responsible for making sure that not only were we doing something that worked, but that we're going to disseminate it, and it need to be ready for dissemination. And so right now, as I said before, functional family therapy is serving around 50,000 kids and families worldwide. MST is serving, even though they have more sites, they have a smaller caseload, they're serving probably in the neighborhood of 20 to 30,000 families worldwide every single year. And that's just two of the evidence-based models. When you start looking at nurse home partnership, David Olds' work, they're now finally starting to grow. The challenge for a lot of this work is what's the funding mechanism for making it happen? And so with David Olds' work, where you're going to go in and do prenatal counseling to at-risk moms, who pays for that? They spent a decade lobbying to make sure they could actually get a line item in the federal budget for doing appropriate prenatal care. Evidence-based prenatal care. And it became part of Obama's stimulus package and part of the Affordable Care Act. It's in there. 1/3 of that money that's in there, and we're talking billions of dollars here, 1/3 of that money goes to evidence-based programs. The other 2/3 go to faith-based programs, and programs for which there is no demonstrated efficacy to maintain the status quo. But that's the way the real world works. 10 years to get 1/3 of that pie. And it's by far the most powerful and most cost-effective strategy we've got. In Florida, there's good news and there's always bad news. In Florida, unbelievable. Wansley Walters, the DJJ secretary, she was actually here at the Jack when the Jack's first opened. She was the first chief at the Jack here in Miami. We started working with evidence-based associates and community treatment providers throughout all of the districts here in Florida. MST, BSFT, and FFT were three of the most prominent interventions that were being implemented for kids that were one step away from being removed from their home. And so these kids were going to be put in jail, typically a level 8 placement, level 6, level 8 placement. And so they were given one more shot in the community, or they were going to go to jail. And looked at these multiple evidence-based models, we were able to drive the recidivism rates over a 7-year period down from what, at the end, for treatment as usual, it was around 45% of the kids were within 1 year getting rearrested and typically incarcerated in treatment as usual, to around 17 or 18% of the kids that were receiving the evidence-based programs. Pretty good. In functional family therapy, those kids, on average, we were able to treat in 89 days. Within 3 months, we were getting these kids through treatment and keeping them out of jail. MST was getting powerful results also. If you guys want to see an article in Criminal Justice and Behavior on this, Baglivio from DJJ in Florida published a paper that demonstrated these outcomes. It's estimated that over a period of time from 2006 to 2013, these interventions saved the state of Florida $93 million. There was a change in leadership. There were some issues around Medicaid. There were decisions that were made at the highest levels about funding the programs. MST and BSFT and FFT walked away from the state because we could not in good faith say we could do the interventions anymore. This program went away. There's some version of it that's there, but it's skeleton now. So it's tough to sustain this stuff even when you're saving $93 million over that period of time and getting great outcomes. It was reducing, it was literally a 500% reduction in recidivism when you look at the odds ratios. It was powerful, and it went away. So a few things that I'll talk about at the end on this one. It's not all great news, but there's some good stuff. This slide's out of place. I'm sorry. This is one I should have moved, Danielle. Sorry about that. This one goes back to the Washington State Institute of Public Policy. It's an older slide, but when you get on their website, this is how they organize the information. Quickly, you can actually look at a bunch of programs and get a sense of how effective they are within Washington, how much they cost, and what are the benefits for every dollar you spend in terms of the long-term outcomes. And they also look at it by the victims and by community level costs as well and benefits. This is kind of a nice place to go if you want to learn more information about evidence-based work. So back to the not so good news. In functional family therapy, we can get zero effect. In Washington, we got no effect for one of the first implementations that we did when we came right out of the gate from Blueprints. Early 2000s, we just started on this one. What we found is that treatment as usual was every bit as effective as FFT when you look at it in general. You had to break it out by competent adherence. Therapists that were not adhering to the model were actually getting worse outcomes than treatment as usual. Therapists that are adhering to the model get better outcomes. So most of the interventions that you're going to see, like FFT, have developed over a 15 to 20-year period really intense and rigorous procedures for making sure that therapists are able to implement interventions with integrity consistently in the real world. The thing that drives therapists off model the most is the level of externalizing problems. When you're working with therapists in the real world, their go-to places, their comfort zones, are where they go when things get the hardest. And typically the comfort zone involves some form of challenging or becoming one-up with their kids that they're working with when the kids come in demonstrating this externalizing. They do exactly what we tell them not to do. And so you have to have a system in place for helping therapists to have the confidence to continue to do it in the face of the most difficult cases to ensure that the families that are most in need of the services actually get them. Cleaned up the slide for you. I didn't want to have you guys get offended. So this is done via supervision with adherence and fidelity to the model. In every single one of these approaches, there's an intense training period. Every one of the therapists in functional family therapy will go through 10 days of didactic training during their first phase of training and weekly supervision with an expert. And then there's the evolution of a member of the team to become the supervisor over time. MST operates in a very similar way. None of this can actually work if you don't attend to the context in which you're doing this. So there are groups at Texas Christian University, the group at the National Implementation Research Network, NIRN. If you guys want to get on and look at the Global Implementation Conference and what NIRN is doing there, they're talking about what you need to do as a community to really support the implementation of an evidence-based model. The last little piece here, this slide, that little bullet point number 3, is implementation. But there's a ton of work that goes on beforehand to make sure that people know what they're getting into. Where's the funding coming from? Is there a long-term plan for sustaining funding? Who are the stakeholders in making those decisions? What's the agency who's going to be pushing this forward? What is their relationship like to the stakeholder? Are there other stakeholders that are at play here that are going to be funneling referrals to you? Might be great if you're getting money from this pot over here, but if you don't have a connection to the parole officers, you're not going to see a case. So you got to make sure you bring in the right stakeholders into the mix. All of this needs to occur prior to implementation. What can happen, though, is people become so focused on making sure you line up every single one of these that you can talk for years and never implement anything. And so there's this challenge between how much is enough to be able to move forward. We tend to operate a little more on that, we're going to go in there and we're going to pray a little bit and push things, but you got to have the initial stakeholder meetings up front. When you're able to do this and do it in a community development team framework, bringing multiple agencies together, The loss of teams, because this is an investment that people are making. Communities make about a $40,000 investment to bring one of these evidence-based programs in and train people in the model. If you lose them after a year, it was a waste of time and effort. So we try to work really hard on setting up the entire system to support that team is going to be in place long term. Does this make sense so far? I'm kind of jumping around a little bit, but I'm running out of time, so I wanted to make sure I at least hit on some of the highlights. I am on a call at 11 today with one of the NHS workers from Scotland, who holds the money for the implementation of a new FFT team in Glasgow. And that's just a stakeholder conversation you got to have. Otherwise, you're not going to have the support. Thanks. You're not going to have the support to move this forward. There are intermediaries that are now functioning in this role in a lot of places. Evidence-Based Associates was an intermediary that went and lobbied to the state of Florida and actually got the money, and then worked really hard with DJJ and community providers and the evidence-based models to bring them all together. So there are a variety of people that are serving in that area. So those of you who are new in your career and you're looking for jobs, there are jobs out there in the evidence-based area, and it's not always as a therapist. There are other options that are there. Two things on this one. The sustainability of programs was actually much greater for programs that went at it together. They had better utilization rates, meaning they had cases that were coming in and being seen. And that's really critical because low utilization is the greatest risk factor for the loss of a new team. So a few concerns about evidence-based practice. I don't know how much you guys have heard about this or this has been part of conversations or how much you feel this way. There's really a concern that a lot of skepticism about, you know what, these models are really just cookie cutter. They come in with a manual and it's, you know, they're not creative. They really don't match what you need to be able to do to really address the types of problems. You need to have more flexibility and dexterity, and they're too rigid and inflexible. You can't come at a complex problem with a simple manual. You need to have much more available at your fingertips in order to be effective. One of the other ones we're hearing a lot about now, I get this one a lot in the UK, is this branding of evidence-based programs. You know, it's really not about the brand. It's not functional family therapy. It's not multi-systemic therapy. This is about family therapy. And so the family therapy is family therapy is family therapy. I don't care what brand you have. As long as you're doing these things, you're going to get good outcomes. So that's kind of a different piece that's come up a lot more recently. You see this in some of the meta-analyses that are being done that are looking at kind of pulling together a variety of treatment parameters that might be associated with outcomes. And so Mark Lipsy's work is a great example around the SPEP program that he's been developing, looking at program implementation elements. Do you have a manual? Do you have a training structure? Are you serving the right clients? That's the kind of things they'll ask. And it doesn't matter whether you're doing FFT or MST. It matters that you're doing a type of treatment. Family therapy, individual therapy, or group therapy. And so the idea is they pulled all this data from a variety of implementations to try to come up with that type of thing. Another way you see this is in the modularization of treatment or the training in core competencies rather than models. So it's not the models themselves that are associated with the outcome, it's the core competency. I'm going to skip to that one really quick. There's very few studies that actually look at core competencies, though. In one of the only really program of research that I'm aware of looking at core competencies in family therapy, we broke down what it was that therapists did in BSFT, FFT, and multidimensional family therapy to try to get a sense of whether or not there were some core elements that were present. We looked at dropouts versus completers, and we looked at early session process because this is incredibly intensive research to do. We literally coded moment to moment what it was therapists were doing in the room. And when you look at BSFT and FFT, they always work conjointly. The whole family's present. MDFT includes a mix of individual and family sessions. So we picked 3 variables to look at that we thought might represent more of what would be considered a core competency. And there really is no variable that's more prevalent than the therapeutic alliance, the relationship with the therapist. What we ended up finding is when you look at those early sessions, to discriminate dropouts from completers across models, alliance was effective. Just looking at that variable, yeah, alliance seems to be a core process in discriminating dropouts from completers, but not the same way across the models. In the conjoint models like BSFT and FFT, it was not the overall level of alliance that made a difference. It was actually the unbalance in alliance made a difference. If therapists were over-connected with parents and under-connected with kids, that was associated with dropout. And in fact, nowhere in the data set was alliance highest than among parents in the cases that dropped out. So you get a parent coming in and going, this kid's the problem, this kid does this kid does that, and therapist doesn't do a good job balancing that, you're going to lose those cases. In MDFT that worked individually and conjointly, the overall level of alliance did make a difference. When you looked at therapist support, therapist in cases, and this was pretty consistent across the models, therapist in cases that dropped out of treatment were 7 times less likely to send a supportive statement to the adolescent. Typically what they'd end up doing is reflecting back to mom. He did this, that must be very hard for you. Great Rogerian reflective technique, horrible intervention in family therapy. It gets you more negativity, it gets you more blame. Even more deadly is going, yeah, so it sounds like your mom is really pissed off at you. That just gets you more back at it. More deadly in FFT and MDFT are those types of statements because they engender more conflict. MDFT and FFT both systematically go after negativity and blame in early sessions to try to smother them and reframe them. And what you see is cases that complete treatment have lower levels of conflict by the end of the first phase of treatment than those that drop out. So those that complete have lower levels than those that drop out. In BSFT, which is based on Salvador Minuchin's structural family therapy, and the focus is on facilitating enactment so you can observe in the room what it is families do at home, higher levels of conflict were seen in the completer cases than the dropout cases. The entire flip side of it, because therapists were doing what they're supposed to be doing. They were facilitating enactments with family members and getting the negativity out there. So it's important to kind of keep in mind that, yeah, there may be some core processes, but given that most of you guys are family therapists, you know, what it is you're supposed to be doing in your theory matters. The context matters. Just going and starting to push for saying, you know what, we can go to these core competencies or something else and move away from a brand, you better know what it is you're trying to accomplish because you can undermine yourself because you'll be doing things that are theoretically incompatible. What we're seeing more and more is the families are more confused by what's going on in treatment than the therapists are. When you send them mixed messages about who the problem is, we're working hard to remove a kid from being the identified patient. We're trying to give everybody in the family dignity and nobility in their actions rather than being seen in a way that's being disrespectful and blaming. What's the dignity in their action? And then you go, you know what, I'm going to give you this assessment measure that talks about all the crap you're doing to each other. Mixed message. You know what, this isn't about you, son, this is about the family, but I'm going to send you to group therapy. You know, Dad, you know, what you did, you know, you got all these things happening now. You're going to have to go to this group over here to manage your anger. But you know what? You're a great father, and you know, this isn't really just about you. When you start sending them mixed messages like this, they can't organize the treatment very efficiently. You lose people from the process. So we need to do a better job of thinking through these types versus brands, and also thinking through what it is we're actually requiring our families to do when they're doing the work in the real world. Just kind of last things. I've already said most of them. Providers and consumers, and I think this is going to become even more the case as we move forward now over the next decade, are going to be having less of being able to have less of a role in deciding what their own care is going to be. Most of what you're going to see is still not going to be evidence-based in the mental health profession. And so I think we need to do a better job of making sure that as professionals coming out and trying to work with families that we work with, we need to really alter our training programs to be better informed about the role of science and practice. Understand what it really means. I think that we owe it to our families to be accountable in that way. I think that this cuts across, not just psychologists, although we're to blame also, but we got to really help marriage and family therapy training programs, and we have to help a lot of the social workers that are out there doing a lot of this work on the front lines to be better educated about what evidence-based programs mean, and give more exposure, not just to the scientific methods, but actually the grounding them in the reasons for this and the policy implications that are there. Because people tend to really value their own personal experience more than the research evidence at this point. They tend to see, their impact and their own experience is more relevant than some research study that was done in 1992 at the University of Utah or in South Carolina. So in some ways, and this is maybe getting a little too bold and maybe a little too combative, a lot of times our practice really mirrors more of what medicine looked like in the early 1900s. Rather than what we should be doing as professionals. I think we owe it to our families to do a better job there. We need to be providing interventions for which there's the strongest sense of efficacy. And I'll bring this back to the CDC slide about mortality. This is about saving lives. And if we are in the business of saving lives, then we should be looking at numbers, because a 10% increase is actually quite meaningful. If that's cancer treatment, that's a huge impact. And so we need to do a better job of kind of pushing that out there and being willing to put our stuff out there to be reviewed. I think we need to do a better job of really helping people understand that a randomized controlled trial is only part of the picture. There need to be other mechanisms for actually helping people to do evaluations of their own work, and to help them understand how they can actually evaluate the work they're doing in the real world. This will be achieved through really increasing plausibility of evidence-based programs to practitioners in the real world. It doesn't come through being critical of how people have been trained. It comes from matching to folks and figuring out ways to find new ways into the conversation. Most of the therapists I've worked with in the UK and a lot of places in the States, basically we show up and we're just another training they come to. And it's like, last week we had this, last year we had this one, we were told this is how we're going to organize our practice, and now here you are. And there's just a lot of skepticism about, really, is this going to stick around? And so why do they really put a lot of investment in that? And so we work hard to make sure we localize the expertise in those teams so that they can actually sustain over time. We have FFT teams now that are 15 years old after that Blueprints initiative. So this can be done. But it requires systematic effort to really move things from evidence to practice, and to listen to the practice-based evidence arguments as well. I'm doing a study now with MST where we're interviewing supervisors and therapists from MST and FFT about their ground-level experiences where it's difficult to implement the models. So that way we can actually do a better job of matching to what our therapists are struggling with. In all of our work with FFT, we build a local experience that by 3 years out, we are only in minimal contact with the site, and it's almost all done via data rather than through any types of conversations. If you can't localize things and build that experience, these things will go away over time. They're inherently unstable. Providers need to remain open to the importance of scientific scrutiny and accountability as determined by measurable outcomes. We need to do a better job of actually evaluating our impact in the real world. And I think that's where a conference like this and where you bring practitioners and researchers together is critical. What's happening right now is a lot of the decisions are being pushed into academic settings in different places of the world. So the academicians are making decisions on treatment providers, and they have no experience with the providers themselves. So it's got to be a two-way street where you're actually having people trying to bring in the evidence-based programs that are working the best. We're seeing educational psychologists now making clinical decisions about an entire course of treatment for youth in Australia and youth in Scotland. And those educational psychologists have no experience or training in any of that. So we have to do a better job of helping people to know what it is we want to provide, how we're going to provide it, and how we're going to measure it. And just a couple of final things, and I'll open it up for a few questions. Bar is not raised by maintaining the status quo, and the status quo is not very good, guys. Recidivism rates for the kids in Florida, for that study I was telling you about, it's around 45 to 50%, with about 25% of the kids actually getting through a course of treatment. That's not good enough. We got to do better. And I think that we really, as a profession, owe it to the families to be accountable for our work. They deserve the highest quality of care, and I think it's our responsibility to get it to them. So I'll leave it at that. That's soapbox 101, right? Yeah. So we do have some time for a couple of questions. I'm sorry, I went a little bit over. Yeah.
So many years ago, I worked at DJJ, and I'm just wondering if it's specific to Florida because we are a large state, that they would remove that funding, or are you seeing similar things in other states?
Yeah. So the question is it specific to DJJ because it's such a large state that we ended up losing the funding stream? No, it's not specific to DJJ. The New York Times had an article about the new commissioner that's come into ACS, Administration for Child Services. And I'm excited because he looks like he's an evidence-based guy. And he's really supporting evidence-based work. And it was interesting because they didn't actually cite the last commissioner. They cited the commissioner before them that actually brought in, and through literally is hundreds of millions of dollars spent, to convert 33% of their system. The largest child welfare system in the world, they converted 33% of it to evidence-based practice. And it's been a fight, nonstop, to keep it in place. And so now with the new commissioner coming in, we hope it will sustain. When we lose teams, when anybody's losing teams, it usually is you've lost a key stakeholder who's making a decision about the money. And then you lose it. So it's not unique to DJJ or Florida. It's pretty common. And the bad part about a lot of this is people want to come in and put their stamp on something immediately. And oftentimes the place where they're going to put their stamp on are programs that look the most costly on the surface because it costs anywhere from $20,000 to $40,000 to get trained in some of this stuff in the first year. So it looks expensive. But over time, it actually saves money because you're getting better outcomes. But a short-term thinker just says, we're going to get rid of this. And typically the lobbies, we suck, honestly. In general, the family therapists are horrible about marketing our own stuff. I wasn't trained to market this. I wasn't trained to be a business guy. I'm terrible at it. I give it away usually. I'm just horrible with that kind of stuff. We named it functional family therapy, for God's sakes. How much more boring could you get? We're not good at that kind of stuff. But a lot of these providers have been there on the ground for a long time, and they're very well connected. And there are also lobbies, there are unions and things that are fighting at multiple levels, and that is to maintain the status quo. So that's not just DJJ. Yeah.
Yeah, thanks. I have a question, and I have a statement. Let me do the statement first. As a practitioner, psychologist in private practice, a lot of times getting training as an individual in these evidence-based practices is way too expensive, period.
Yeah.
And oftentimes I make choices based on what's in the public domain or programs that have really made a point of making dissemination and availability to practitioners affordable.
Yeah.
I think that's a real crucial piece here.
Yeah.
Yeah. That's a statement. The question that I have,
and I'm not going to disagree with that statement. Yeah. You're absolutely right. Yeah, absolutely right.
The question that I have has to do with giving mixed messages during family therapy sessions. You had mentioned that if we're working with a family and we're then suggesting that one family member go out and do anger management training, then somebody else needs to do this group or whatever. Oftentimes when we're making recommendations as a psychologist, I'm a child protection team psychologist along with a variety of other things, but we're expected to make a lot of recommendations, and oftentimes along with family therapy, I will make recommendations for a lot of other types of treatment. Is that counterindicated, or what are your thoughts on that?
Great question, and it's a complicated response, but I'll try to be incredibly brief. One is the fact that you're from a CPS group trying to make those decisions in an informed way is the first part of the battle. Having one person on the point that's in control of a case is critical. And then layering in other things that might be relevant over time becomes easier than trying to start with all of them up front. That early engagement and motivation part of treatment can pave the way for a lot of other services if it's done appropriately. And so a program like FFT and other of these interventions, they play very well with others, but it's a matter of when. And so I'd want to work very closely with a group to make sure that if there are other things you want to see done, they're going to get done, but they'll be done at certain points in time. And so you layer in like an anger management or a group for a DV early into the treatment process because it has to be there, because you can't, the stakes are too high. But we want to have this be done at the end of the first or into the second week as opposed to being part of the initial treatment plan. Because what happens is that starts getting in the way of the treatment process. A lot of it becomes crisis-oriented as opposed to treatment-oriented. And so we'll want to kind of move it back as quick as, back in that process just a little bit until we can motivate them. So multiple services are okay as long as it's not a shotgun. It needs to be planned and thought through. And not just because there's a list of things we do, they need to be matched to the family. Yeah. Your first point, I wish that it was easier, but right now the way the whole structures are for some of these programs is they're built around creating teams, and we're exploring ways of actually breaking down some of those barriers to bring teams of folks together. And that's not an easy one, but you're right on. It's not really affordable for a private practitioner to be doing it. Yeah.
My question is just a kind of a piggyback on that question. I'm part of a large graduate training program. To what extent do developers of these various family therapies, have connections to training programs? And wouldn't that be, since we know that people generally tend to do what they were trained to do when they were, in their graduate training program?
Yeah.
I find that the connection between a lot of these developers and graduate training programs is not what it should be.
Yeah.
Is there a way to improve that, and are you aware of any efforts to do so?
Yeah, you're right. I think we all kind of end up in our own little kingdoms, and it's not. And most of them actually were developed within graduate programs, then expanded out, and then just kind of lost those connections. We have two programs that we've just started, one in Indiana and one in California, where we are replicating our training structure, but making some alterations that it's part now of an ongoing practicum experience for students in marriage and family therapy programs. And so we do have two places where we're doing it currently, and we're supporting a faculty member to emerge as the team lead and supervisor. And I think it's great because it's also seeding kind of the next generation of research. So there's an opportunity there. I would love to talk to you more about it too. Yeah. All right. Thanks, guys, for your attention.